I would like to invite up our International Excellence in Medicine medal presenter, who, Klekamp, is really a scientist as well as a neurosurgeon. I know him more as a scientist, but he is also exceptionally well-trained neurosurgeon that works out of Hanover, which is one of the great neurosurgical centers in the world. So, without, please come. Congratulations on the
Well, first of all, thanks very much to everybody and to the Bobby Jones organization for awarding me this prize. I'm very honored and I'm delighted to be here, although it was a bit tricky to arrive today, but that's a different story. I knew that John would talk about arachnoiditis, so I thought I'd use a different topic rather than two people talking about the same. So I choose Chiari-1 malformation, which happens to be the disorder where most patients with syringomyelia are associated with. You already heard that syringomyelia is always a secondary phenomenon to an underlying disease, and the most common of these diseases is Chiari-1. Now I have to work out how to advance. Let's try, yeah. When I started getting interested in syringomyelia and Chiari-1, I was introduced to these two gentlemen. As you can see, the guy in the middle was a bit younger than he looks now. The person to my left is familiar to you all, I'm quite sure, Rick Batzdorf. I will show you another picture that will demonstrate that this man doesn't age. And to my right is the late Bernard Williams, which unfortunately passed away a couple of years after this photograph was taken. This was taken in Hanover at the Skull Base meeting in 91 or 1992, I'm not quite sure. I was very honored that these giants in syringomyelia and Chiari surgery actually somewhat adopted me to some degree in order to teach me what they thought about syringomyelia and Chiari, listening to a young resident's ideas, and that was very, very special. This photograph was taken more recently in Long Island. As you can see, as I told you, the guy to my left hasn't aged at all. And the other one to my right now is Arnold Menezes, another neurosurgeon that was very important for my clinical work, in that his ideas and concepts shaped the way I was approaching craniocervical malformations that involved joint problems like basilar invaginations, for instance. And this is Rick recently at an exhibition of his paintings. Now, Chiari-1 malformation has been treated for quite a while, almost 100 years. The first one to operate on it was a Dutch fellow, van Houweningen-Graaftijk, in 1932. I don't know what came out of this operation, but you have to imagine no microscope, no CT scan, no MRI. So I'm quite lucky that I hadn't to operate at those times. The next person who actually laid the foundation for decompressive surgery of Chiari was certainly Gardner in Cleveland, who in 1958 proposed to do an occipital craniectomy, plug the ovaries, and they also left the dura open. This worked quite well for some patients and was a method to actually treat the syrinx and the Chiari malformation in one single operation. However, this operation was accompanied with quite high mortality and morbidity, making it not very favorable to neurologists, so that many neurologists didn't refer their patients to neurosurgeons because they thought this may not be the best idea. So people started thinking, how can we reduce mortality and morbidity? Because the concept of decompressing has something in it that should be worked on. The next person who actually developed this further was Bernard Williams in the 1970s. He reduced the size of the craniectomy because he found that if you do a too large decompression, the whole cerebellum may sink down and you get the same problem all over again. He also emphasized that it's important to dissect the arachnoid, and he avoided obex plugging. He said that's not necessary, it just causes morbidity, but he also left the dura open. Another person from England, Victor Logue, also tried to reduce the surgery to a degree in that he said we don't open the arachnoid at all, but we do a duroplasty. These two changes in the technique lowered morbidity and mortality considerably. And then Ulrich Batzdorf introduced the technique of bipolar tonsillar shrinkage of the cerebellotonsils, which is another very nice method in order to improve the size or to increase the size of the subarachnoid space at the foramen magnum. He also emphasized to do a small craniectomy, arachnoid dissection, and obviously a duroplasty. And this technique that Rick Batzdorf proposed is the one I've used since my beginning in this field and haven't changed much through all the years because it works extremely well. Here's an example of a young male person, no neurological symptoms, but suboccipital headaches with Valsalva. You see the chiari, you see the large syrinx. It's operated in the prone position. Hopla, that's not what I wanted. Here you see the dura of the posterior fossa. Here's the dura of the upper cervical spine. Then the dura is opened. You see the arachnoid and the tonsils underneath. The arachnoid is opened. Then the tonsillar tips are coagulated with bipolar forceps on both sides so that one gets a view into the fourth ventricle. The obex is here. Gardner would now put a piece of muscle in here in order to prevent CSF to go from the fourth ventricle into the syrinx. That was his theory. But we now know that this is not necessary, and to the contrary is very, very bad for the patient. So this is the site that you get. Then a duroplasty is put in, and that's it. And this is the result that you get regularly. Before surgery, CSF flow obstructed. After surgery, CSF flow established. The duroplasty enlarges the space for the subarachnoid fluid, and the syrinx collapses. This works extremely well. In my personal series, I've always used this technique. The only changes I've made were with the dura material used for the duroplasty. Lyophilized dura was abandoned in '95. It was taken off the market because of Creutzfeldt-Jakob disease. Gala and fasciolata was then used, but we abandoned that because the results were not as good as we would like. And I've used Gore-Tex since '98, and I'm happy with the results ever since. And these are the results long-term, and that's basically my major argument why I still propose that this is a technique that should be used. First of all, you get a decrease of the syrinx in more than 80% of the cases. The surgical morbidity is below 2%. Reoperation rate, 1.2%, very low. If you look at progression-free outcome, you can see that for 5 years, 93.3%, for 20 years, 87.3%. It's very, very difficult, in my opinion, to improve on this technique. And if you want to change, if you want to propose something different, you have to prove that you get at least these results. Otherwise, you should stick to the technique that I've just outlined. So to me, the gold standard of foramen magnum decompression for Chiari 1 is established since '88. That's my view. However, some other people try to use other concepts or try to improve, look for alternatives that may be less invasive. One was keyhole surgery, proposed by the neurosurgeons in Mainz in Germany with Axel Pernetsky and Hüvel. However, their results for Chiari 1 with this technique were devastatingly bad. They used an endoscope not to perforate arachnoid adhesions, but to resect one cerebellar tonsils in order to improve the cerebrospinal fluid without doing a duroplasty, without doing a craniectomy. But it's several devastating results were caused with this technique due to injury to important vessels like the pica, but they never reported them. So this virtually was abandoned. I don't know of anybody using this, fortunately, anymore. The other minimal invasive concepts considered to avoid dura opening and to avoid duroplasties, like decompression with incision of the outer dural layer only or a bony decompression only. This is called posterior fossa decompression, PFD, without duroplasty, although foramen magnum decompression I would prefer to call it. And this is compared to the posterior fossa decompression with duroplasty, as I just outlined it, but it should be foramen magnum decompression. But this is a semantic problem that we don't have to discuss here further. The question is the bony decompression providing the same results as the full program? It's certainly less invasive. The patients stay in hospital shorter, and it is associated with lower costs. But the people who propose this technique also claim that it has lower complication rates and that it is as effective as the gold standard. Is that true? Well, for the first three objectives, it's certainly true. It's been shown in several studies. However, what about complication rates and the long-term effectiveness? That's a different story. Complications. The largest study comparing bony decompressions and decompressions with duroplasty is this one here, which, to my surprise, doesn't get cited that much. This was an analysis of a database with more than 2,500 child cases of Chiari being analyzed, so a very large number. What did they find out? Well, the overall complication rate for the decompression with duroplasty was not higher than compared to the one with the bony decompression only. No significant difference. However, postoperative hydrocephalus also, no significant difference between the two techniques. But yet, the result or the conclusion was posterior fossa decompression with duroplasty is associated with significantly more complications and immediate reoperations, while decompressions without duroplasty are more economical, requiring fewer hospital resources. So it's more favorable. That's not what the figures actually told. So I'm quite surprised that this conclusion was written down, because the numbers they present in their paper tell something different. What is clear is that CSF-related complications, CSF fistulas, for instance, are obviously higher in the technique with the duroplasty because the dura was opened. But otherwise, no difference. So the claim that the bony decompression has lower complication rates can be questioned, and I question it based on this paper. What about effectiveness? Well, the problem is that we don't have long-term studies on the effects of bony decompressions in children, for instance. We don't know how they do in adulthood, to give an example. So, what can we use instead in order to get an idea? Well, we can look at the rates for postoperative reductions in syringe size. If you have a technique where the reduction of syringe size is not very high, it's reasonable to assume that the long-term results will not be that good. Similarly, you can calculate the rates for reoperations to get an idea about the effectiveness long-term of your technique. If we look at papers doing that, then this paper here was published in 2022, analyzed 692 patients, so again, quite a large sample. Preferring, however, as you can see, the technique with duroplasty. The bony decompression was undertaken in only 17% of the patients. They found that the bony decompression was associated with fewer postoperative complications within 6 months. However, the technique with duroplasty was associated with better symptom improvement, reduction in syringe size, and lower rates for revision decompression. So a clear statement that the technique with duroplasty is better. Another study looked at scoliosis progression in children undergoing surgery for Chiari, and they found that after controlling for preoperative factors like age and so on, patients treated with duroplasty were less likely to have a curved progression than patients treated with extradural decompressions. So again, an indication that the technique with duroplasty is better. Lower CSF-related complications, okay, but higher rates for syringe reductions, better clinical outcomes, and lower rates for subsequent revision surgeries for decompressions with duroplasties. So it's still the gold standard, if you ask me. What about Chiari 1 and craniocervical instability, another very much discussed topic? It started with a paper of Milorad in 2007, where he described a considerable number of patients in his patient cohort having connective tissue disorders. And what's interesting when you look into this paper in detail is that he's basically, to my understanding, is describing patients with basilar invagination, with retroodontoid pannus formation, indicating C1-2 instability, hypoplasia of the oropharynx related to a smaller clivus. And he himself says in his conclusion that retroodontoid pannus formation and the necessity to stabilize these patients is probably referable to basilar impression, which is another term for basilar invagination. So craniocervical instability in patients with connective tissue disorders such as Ehlers-Danlos, if I understand the papers correctly, is foremost related to basilar invagination in my view. Another paper came out with the term complex Chiari, describing patients where additional problems apart from the Chiari malformation may make treatment more difficult. Again, this paper and the term Chiari 1.5 more or less refer to patients with additional basilar invagination if you look into the papers in detail and if you look at the figures, the case examples they present. So let's quickly look at Chiari 1 and basilar invagination. That's what we're talking about. You see a line can be drawn here from the palate to the posterior rim of the foramen magnum, and if this part of the second cervical vertebra, the odontoid peg, is crossing this line cranially for more than 3 to 5 millimeters, we say that's a basilar invagination. And as you can already guess from this image here, if this goes further, you can get a compression from the front, and if you have a Chiari, you get a compression from the back, so the spinal cord is getting compression from both sides. Additional features: shortened clivus, that's this bone here of the skull base. Reduction of posterior fossa volume, because the clivus is shortened, the odontoid is pushing up. The space here for the cerebellum is reduced, so the Chiari results, because that's the way the cerebellum can sort of grow and use space that's available. Reduction of pharyngeal space we already mentioned. Patients with basilar invagination commonly have a Chiari. They commonly have a fusion of the first cervical vertebra to the skull base, and congenital fusions of other vertebral bodies as well, which is called the Klippel-Feil syndrome. But is C1-2 instability present in all these patients? There are two classifications trying to somewhat describe which patients may require stabilizations, which ones not. And the Menezes classification, dating back to 1980, states that if there's no anterior compression and you find that there's no mobility in functional studies, then you only do a posterior decompression for your Chiari. You don't have to do a stabilization. So there are patients with basilar invaginations that are stable, according to his classification. The original classification by Goel says basically the same. However, he describes patients with a C1-2 dislocation. That means first and second vertebra dislocate from each other. I will show you an example shortly so you understand what's meant by this. This type of dislocation requires fusion, and if there's no dislocation between C1 and C2, he considered this as stable. Only a posterior decompression is required. So it's a similar classification than the one by Menezes, just a little bit different put together. General agreement nowadays: basilar invagination with atlantoaxial dislocation requires realignment and C1-2 fusion. However, what about basilar invagination and no atlantoaxial dislocation? Is this stable or is it unstable? That's controversial discussion. Criteria for stabilization, in my mind: ventral compression of the medulla by the odontoid peg. That is something that should be treated with C1-2 stabilization. When the patient has symptoms of nystagmus or neurological symptoms provoked by head movements, this is also an indicator that craniocervical instability may be present in the setting of a Chiari 1 and a basilar invagination. Example: here you see such a dislocation. That's the anterior arch of C1, that's the odontoid peg. This part of the bone should be down here, so this is a dislocation. You can also see that here C1 is slipping over C2 in the joint anteriorly. This is a clear indicator of instability. What you do is realignment by extension, basically pulling out the odontoid from the skull downward. Here it's realigned, and in the realigned position you fuse and do the decompression. That's the result. Here's another example: no ventral compression, no dislocation, Chiari and a small syrinx, but the patient has ataxia with head movements, and breathing problems with certain head movements. So this is an indicator to me that C1, C2 is not stable. In this case, we did the decompression and a C1, C2 fusion with a very good clinical result. Another example, ventral compression, as you can see here by the odontoid, no dislocation between C1, C2, syrinx, and a Chiari. In this case, we did the decompression and a fusion C1, C2 in a slightly retroflex head position, just a few degrees. And as you can see, here the cervical cord is no longer compressed from the front, and you have the CSF flow posteriorly. This example, no ventral compression, no dislocation, no signs of instability, so just a decompression, and the patient does fine. So, the decision for C1-2 fusion in Chiari 1 should not be based on the diagnosis of a connective tissue disorder, in my opinion. If you have to decide for C1-2 fusion, it's because of patients with additional basilar invagination and atlantoaxial dislocation, ventral compression, or neurological symptoms provoked by head movements. CO-C1 fusion is not indicated in patients with Chiari 1 in my opinion, and should not be undertaken because the problem, if there is one of stability, it's in the C1, C2 segment. Now, Chiari and C1-2 instability, we have to mention Goel's recent thoughts on this problem, and he thinks that all patients with syringomyelia are basically related to atlantoaxial instability, which I consider a wrong statement, but that's what he's proposing. And I tried to study the problems or the features that he presented. I don't want to get in too much detail now, but in summary, you can say that for adult Chiari without basilar invagination, there's no indication for instability in the patients that I could study. However, in Chiari with basilar invagination, facet displacements and ventral compression are the other signs indicating that a C1-2 fusion is required. This is a large literature review done by German and Austrian colleagues a couple of years ago. At present, there's no evidence supporting the hypothesis of atlantoaxial instability being the common progenitor of craniocervical junction abnormalities. So for Chiari 1, the surgical options are outlined as you can see here. From my point of view, bony decompression, arachnoid dissection, and duroplasty is the way to go. And that's a short summary of what I've presented in this talk. And thank you very much for your attention.
Stay here. Dorothy, here.
So this room is filled with people who I adore, who have walked many journeys. I feel like with me at different points in my life. Rich, you were the person who actually started off this group. I don't know if many people know that, but he was the one who was behind, with Paul, with Lori, Ed Benzel. There was that little small group decided that we should go and pursue research. So you're with the journey. Walter goes back to like when my son was diagnosed, and he was a resident, so we're pretty old together. Lori, who's a dear friend, and her son, Fraser and Becky, who have seen this organization grow through these events. Catherine, who has taken care of my dogs, who have Chiari and Syringomyelia throughout the years. Sandy, who everyone should actually applaud her this year, right now. So she volunteered to be the yeoman for making this event possible. So tomorrow night, you're going to see the spectacular event that Sandy has laid out for us. I'm looking around. So Eric, right? Everybody's getting called out. It's good, though. Eric Jackson, who's from Johns Hopkins, who is probably this interesting guy, and he always teases me a little bit, like what I always say, what is Chiari? Right? Would you say that? What? I say that. I do say that because I'm not sure we figured that all out yet. I think it's a comorbid thing. Dr. Heiss, John, I've known you, I don't know how many years, since ASAP days. And you've been true, steadfast, ethical, very many things that I admire in this world. So I thank you for being part of that. Miles, you've done all kinds of work with neuroradiology. You're one of the people, and Sarah's in here too, so I think you're another person who's going to sort this all out for us as neuroradiologists. Where are you? You're hiding in the back. Okay. Ty, Board of Trustees. You are the people who are, I'm getting old. You are the people who are going to carry this forward and continue the research that all of these people have laid out for us. So I'm looking to all of you to do that. James, so James, interesting person here. He's the one person I think with this group who has kind of no connection to Chiari or Syringomyelia, and yet he's on our board of directors and then moves to the chair. So I think you should ask him why, if he has no connection to this, bioengineer from Georgia Tech University, why are you here? Why do you think this is important? It's not that he is a child. You know, I got started because I had a child. He doesn't. And yet he took on this whole role. Professor Klekamp, let me address you properly. Thank you for all the work you've done in Syringomyelia. I'm a true believer in that the one thing that we've missed here in the US a little bit is that we have to collaborate worldwide. If we're going to make a true difference around the globe, it means collaborating with all the universities, all the people who are around the world, and putting all of that data into a data lake where then it will benefit not only the US, but worldwide. So I thank you for your contributions to this. Who did I miss in the room? Well, the Wyckoff family's here. So I'm just gonna say that thank you for supporting this. Thank you for being here. It's a very important cause. I think that a lot of times we don't, it's not like cancer where people say, well, there's this immediate rush to figure this out. But I can't tell you the number of people in this world who are affected, that have children, that have parents, that are suffering from this. So it doesn't make it any less important. And that's why we have to find the funding. We have to go forward with the research. And you're all here tonight, so I want you to be the ambassadors for that going forward, to find the way to find the answers. And last but not least, there were like 3 people here. So Caitlin's kind of an underdog. She doesn't always get the recognition she needs. She handles the whole data set for over 20 institutions. We're managing that. And it's because she's taken that role and been with us how many years? A long time. She's grown up with this and she's continuing to make a difference. My daughter Mary, who's volunteered for years as well, who has a brother, and the legacy's going to continue because she cares. She saw what her brother was older. She wasn't as aware when she was little, but she understands, I think, the whole purpose of this foundation. So I know she's going to be steadfast in moving this forward. Who I didn't introduce, or maybe you haven't met tonight, we have our lovely opera singer who's going to entertain us, Alexandra, who's from the Ukraine. So I'm going to mention her tonight because I'm seeing her here. And together it's the community, right? It's the community that makes this happen. So all of you have a role. I'm very grateful and thankful that you're all in my life. And I hope together we can actually bring forward the research now that we have all these great techniques and things that we can use, and really truly find the answers for the kids, the families that are suffering from these disorders. So thank you all.